Bismillahirrahmanirrahim. Assalamu alaikum warahmatullahi wabarakatuh. A very good evening to all the doctors who have gathered online for today evening's seminar webinar entitled Leukemia in Children, organized with the Pediatric Club in affiliation with NMC Specialty Hospital and Vitobiotics. To start with, I would like to introduce Dr. Sohrab, the president of the Pediatric Club and senior pediatrician at NMC Specialty Hospital. Dr. Sohrab, please.
Good evening, ladies and gentlemen. Thank you very much, Mr. Tawfiq. On behalf of my colleagues in organizing committee of Dubai Pediatric Club and on behalf of all members of Dubai Pediatric Club, I would like to welcome all viewers from Dubai, UAE, GCC countries, and all countries across the world, especially from India. Today we have eminent speakers from India and UAE. I'm sure there are many viewers from India. This webinar is CMA accredited and it is organized in collaboration with NMC Specialty Hospital Dubai and is sponsored by Vitobiotics UAE. I would like to thank the country business manager of this company, Mr. Tawfiq Ali. I would like to take your permission to share my slides. Is it okay, Mr. Tawfiq?
Yes, doctor.
Once again, I would like to welcome all viewers. As you see, today's topic is the different presentation of leukemia in children. We have eminent speakers. Two speakers from India, Dr. Amita Tarahan from PGI Chandigarh and Dr. Nitin Shah from Bombay, India. We have two eminent speakers from UAE also, Dr. Qassam Gatasha from Tawam Hospital, Al Ain, and Dr. Mustafa Al Baroudi from NMC Royal Hospital, Abu Dhabi. Well, in a short while, I'll be introducing them. We have eminent moderators also, Dr. Kalpana Sengupta and Dr. Rafia Ovara, the members of Dubai Pediatric Club. Well, I always ask the question, who is this gentleman? So you will have 2-3 minutes time. You can write your answer. Those who answer right will give a token of appreciation and will announce their name. Please send your answers to the chat box. Well, beautiful Dubai. I would like to welcome all those who have not seen this beautiful city to come and see one of the most beautiful cities in the world. Members of Dubai Pediatric Club in different conferences, I would like, on behalf of all of them, to invite all viewers to this webinar once again. Members of the Executive Committee of the Dubai Pediatric Club, myself, Dr. Ajindra Joshi, the past president, Dr. Kalpana Sengupta, the secretary of the club, Dr. Diari Muhammad, chairman of the academic affairs, Dr. Muhammad Amir Toleimat, Dr. Ayman Jundi, Dr. Rafia Overa, Dr. Srinivas Bandari, Dr. Leila Al-Bahri, and Dr. Khalid Rashid. Well, as you know, today we are having 4 eminent speakers and panelists. Dr. Qassam Gatasha, consultant and head of Department of Pediatric Infectious Diseases at Tawam Hospital, Al Ain. Dr. Amita Tarahan, professor and head of Pediatric Hematology Oncology Unit at Advanced Pediatric Center, PGI Chandigarh, India. Dr. Mustafa Al Baroudi, senior consultant pediatric hemato-oncologist at NMC Royal Hospital, Abu Dhabi, UAE, and Dr. Nitin Shah, very well known to all, professor and consultant pediatric hemato-oncologist at BJ Wadia Hospital and past president of Indian Academy of Pediatrics. I'll be introducing them again. Well, next month on 27 March, we are having another webinar entitled An Approach to Congenital Heart Disease. We have eminent speakers from India, Dr. Devadatta Mukhopadhyay, very well-known pediatric cardiologist, and from UAE, Dr. Mahmoud Sufi, Dr. Muhammad Sulaiman, and Dr. Samir Sajwani. Detail will be announced later. Well, We have a YouTube channel that is called DPC Annual Conferences. You can see all our webinars, conferences, all there. You can just write it in YouTube DPC Annual Conferences and you can see. Well, Mr. Tawfiq Ali, our sponsor since 2015, he is being felicitated by the father of Dubai Pediatric Club, Dr. Letkui, and others. Well, I'll give a brief history of pediatric hemato-oncology in next 10 to 15 minutes. I always start with the memory of Hippocrates, the father of medicine. Hippocrates said the origin of the word cancer is credited to the Greek physician Hippocrates. Hippocrates noticed that blood vessels around the malignant tumors look like claws of a crab. He named the disease karkinos. In a Greek means crab. This is the beautiful painting. This is the only occasion where Hippocrates was criticized not to treat the soldiers which were who were in the Greece. Well, I would like to mention about pioneers of pediatric hemato-oncology. Pediatric oncology was established in Paris under Dr. Audrey Scott, who is considered a pioneer pediatric oncologist. She established the International Society of Pediatric Oncologists. In French, it is called Société Internationale Oncologie Pédiatre. That is why it is written SIOP. And Dr. Bharat Agarwal is the secretary of this, which I will mention. And our speaker, Dr. Amita Tarahan, is also advisory committee member for this. Just to remember. Now, answer to our question. Answer is Dr. Rudolf Virchow, the father of leukemia research. He introduced the disease as leukemia in Germany in 1847. He is a father of pathology also, just to remember them. Well, a brief history of development of disease. As you see here in 600 BC, it started from the description from Egypt, then explanation of blood with the compound microscope, then first description of leukemia came by Alfred Velpew, the first picture here. Then, as I said, Virchow called it leukemia. Then Newman suggested that leukemia is a disease of bone marrow. And Paul Ehrlich, he's the first professor of pediatrics in Vienna who introduced the biochemical staining. Then it went on to the FAB and WHO classification. Well, in a nutshell, in 1811, Cullen defined the disease as splenitis cutis. And Alfred Velpew, as I said, he said that leukemia is, he described the leukemia-associated symptoms. Alfred Dohn detected the maturation arrest, and Bennett named the disease leukocytemia. I'm going a bit fast just to remember them. And in the same year, Rudolf Virchow defined the reverse white and red blood cell ratio. He, as I said, he called the disease in 1847 leukemia, and Henry Fuller performed the first microscopic diagnosis of disease. They are the pioneers. We should remember them, but one of them, we must remember Sidney Farber. Sidney Farber and his colleague discovered that a synthetic antifolate drug called glutamic acid produced remission of childhood leukemia. And that was a step in the chemotherapy of the disease with antimetabolites and cure of many children with leukemia. More than 70 years ago, Dr. Sidney Farber refused to accept that childhood cancer was untreatable, and his determination led to development of chemotherapy and the first remission of the leukemia. We must remember. Now the father of pediatric hematology, Dr. Diamond, he is considered the father of hematology. Dr. Diamond sets up the first pediatric hematology research clinic in the United States, focusing on anemia. By 1930, he has succeeded in identifying thalassemias. In 1932, along with Blackfan, He identified erythroblastosis fetalis, later called hemolytic disease of newborn. I would like to bring the attention of the viewers, especially neonatologists. He was the first to do exchange blood transfusion in a newborn due to hemolytic disease of newborn. And in 1938, Diamond and Blackfan described Diamond-Blackfan anemia. He also described Gardner-Diamond syndrome and Schwarzman-Diamond syndrome. Well, as you see here, we must remember them: Thomas Cooley anemia, Louis Diamond, Smith, and Sussler. They are the pioneer in pediatric hematology. Well, two of the most important hematologists also we must remember, Guido Fanconi and Edward Glansman, were both Swiss-born pediatricians who made outstanding and lasting contribution to the field of pediatric hematology in early 20th century. Dr. Fanconi, everybody knows Fanconi anemia. He was the professor in Zurich for 45 years, and he is known as the father of modern pediatrics. We must remember them. Well, and something about the hemato-oncology in India. This is the pediatric hemato-oncology conference. I would like to bring into your attention that Dr. Amita Terahan is the president or chairperson of the in this society in 2020. I would like to congratulate her. Well, Dr. Bharat Agarwal has written a very nice article in 2007 in Pediatric Blood and Cancer. I want to remember him. The first specialized service in India for diagnosis of thalassemia in children was instituted by late Dr. S.M. Merchant at Bijawadiya Hospital, Bombay in 70s. Dr. Zinat Komboy expanded the service into the first department of pediatric hemato-oncology at Bijawadiya Hospital in 1988. Please note 1984. And Dr. M.R. Lokeshwar, considered the father of pediatric hemato-oncology and the mentor of Dr. Nitin Shah, set up a similar services at Sion Hospital, Bombay. Tata Hospital, a regional cancer hospital, established a separate pediatric oncology unit for childhood cancer, malignancy, late 80s under Dr. Suresh Advani. And in 1987, the Silver Jubilee year of Indian Academy of Pediatrics subspecialty chapter was initiated, and Dr. Lokeshwar was the first convener of this pediatric oncology. And the first meeting, I think in 1997, was organized in Bombay, and Dr. Bharat Agarwal was the organizing secretary. Now you see here, Dr. Suresh Advani is being felicitated by the President of India, Srimati Pratibha Patel, in 2012. And this is Dr. Lokeshwar, the father of Indian hemato-oncology. He has written a book yet dedicated to Dr. Zinat Komboy, calling her the teacher of the teachers. Well, this is the book written by Dr. Lokeshwar, published by JP Brothers. Now in this book, Dr. Lokeshwar is the editor, Dr. Nitin Shah, our panelist today, and Dr. Bharat Agarwal, they are the editors. Of course, the other co-editor, Dr. Anupam Sachdev and Dr. Mamta Maglani are there. A chapter was written by late Dr. R.K. Marwa, my guru, my teacher, my guide, just to remember him. Well, pediatric oncology as a separate specialty was virtually non-existent in the 80s. There was no formal fellowship program in pediatric hemato-oncology till 2008. The commencement of program such as DM Pediatric Hematology Program initiated by late Dr. Marwa in the reputed institution PGI Chandigarh in 2009 was an excellent beginning. You see here Dr. Marwa, pioneer in this field. Well, I was lucky enough to work with Dr. Marwa, publish few articles with him, and those days continuing medical education in late 80s and 90s. And he was a constant advisor for, giving me advice to publish my book in early 90s, just to remember him. Well, I talked about Dr. Bharat Agarwal. We must remember him also here. Dr. Bharat Agarwal has long been the head of department at Vijayawada Hospital for Children, Bombay. He was the Secretary General of International Society of Pediatric Oncology for many years and continental president of this. Dr. Amita Terahan is also advisor member for this. Here you see a group of, the meeting of hemato-oncologists, Dr. Amita Terahan is here. And what about the UAE, pediatric hemato-oncology in UAE? I found a very interesting article by Professor Humaid Al-Shamsi in the Gulf Journal of Oncology in 2009. If you see here, Tawam Hospital in Al Ain was established in 1979 and in 1983. Please remember 1983, there was a full-fledged oncology referral unit for whole the region, both pediatric and adult. Later on at Dubai Hospital and Mafraq Hospital also, they developed. As you see here, in Tawam Hospital, the pediatric oncology unit was established in 1983, even before India. In India, it was in 1984 by Dr. Thomas Rivers, consultant pediatric oncologist. Same thing was done in Dubai Hospital under leadership of Dr. Abdurrahman Al-Jasimi, senior consultant and head of Department of Pediatric Oncology, just to remember them. Well, now you see here the Professor Umaid Al-Shamsi. He has written a book, Cancer in Arab World, with other editors, and a special chapter is dedicated for this pediatric oncology only in region. I would like to advise all of you to go and see this book. It is coming. Briefly, I'm going to finish just once again to introduce very briefly the profiles already. As we sent Dr. Amita Terahan, Professor and Head Pediatric Hemato-Oncology Unit, Advanced Pediatric Center at Chandigarh. She is also Chairman of the Oncology Section of Indian Academy of Pediatrics. Dr. Mustafa Al-Baroudi, Consultant Pediatric Hemato-Oncologist at NMC Royal Hospital, Abu Dhabi, UAE. Dr. Ghassan Gatasha, Consultant and Head of Department of Pediatric Infectious Disease, Tawam Hospital, UAE, and Dr. Nitin Shah, very well-known Professor and Senior Consultant Pediatric Hemato-Oncologist at Vijayawada Hospital, Mumbai, and past President of Indian Academy of Pediatrics. Well, I'm going to end just by quotation by Charcot. Said disease like leukemia is very old and nothing about this has changed. It is we who change as we learn to recognize what was formerly imperceptible. Thank you very much. My reference is beautiful Dubai. If you have not seen, come to Dubai. Thank you very much. Now, I would like to request Professor Amita Terahan to start her talk, and I would like to request the viewers to write their question and answer. But over to Professor Terahan. Thank you very much. Please.
Thank you very much for inviting me and this lovely opportunity. And it is an absolute pleasure to listen to Saurabh. I have known Saurabh for 25 odd years, and his quest for knowledge and his ability to write books is absolutely amazing, which all of you have heard by his history of hematology oncology. He's condensed 2,000 years into 10 minutes. So that is amazing, Saurabh. And I hope all of you have also had the pleasure of listening to Saurabh's Shairi, which is also as fantastic as his knowledge in medicine. So with this, thank you all so much for inviting me. And I just go on to what our session for the day. And so this was different presentations in leukemia, right? So I'll just start in the interest of time. So I think all of us know that the most important features when we encounter a child with leukemia is fever, bleeding, bone pains, lymphadenopathy, splenomegaly, and hepatosplenomegaly. And once we have, most of these signs and symptoms, the diagnosis of leukemia is sort of clinched. So, however, there are a lot of unusual or different signs, and sometimes the disease can get missed, which is what today is all about. So I just come on to the common features we've just said, and some of the difficult ones or the unusual ones is number one, joint manifestations. We know that very frequently leukemia can present with limping, arthralgias, arthritis is rare, but there's refusal to walk. And it can sometimes be mistaken to be a juvenile idiopathic arthritis or juvenile rheumatoid arthritis. Parotid swelling is not so common, it's rare and called as a Mikulicz syndrome. Subcutaneous nodules or leukemia cutis, which can also be thought to be chloromas, are seen usually in myeloid leukemias. Testicular involvement occurs usually in lymphoblastic leukemias as a painless total enlargement. It's uncommon, occurs in less than about 2 to 3% cases, which for the younger, especially the people in training here, is, one must always remember to examine the testes when you have little, in all boys, because that can sometimes get missed. Ocular involvement is uncommon, in fact, hardly 1%, and patients can just present with hypopia and blurring of vision, photophobia. Pain is comparatively uncommon. Superior mediastinal, superior vena cava, hyperviscosity syndromes can occur, especially in T cell disease. We know leukemia is B or T, depending on the immunophenotype, and this is more common in the T cell. Very rarely, the CNS symptoms are common. Any CNS symptom in a child with leukemia, one should always think that yes, this can be CNS involvement of the disease, which can be anywhere from simple headache, vomiting, irritability, any cranial nerve palsy, visual disturbances. Very rarely, there can be spinal cord compression. A child can present with paraplegia. There can be hypothalamic obesity syndrome if your cells are sitting in your hypothalamus. And rarely, again, it can come like an intracranial cell mass. So when we look at the most common investigation, the first thing we do is a complete blood count. And, most children with leukemia have a more or less normal total leukocyte count. In a very less percentage, hardly 20%, your counts are more than 50,000. Hemoglobin, again, if we look at it, most children have a hemoglobin range in a mild to moderate anemia, and just about 40% will have a low hemoglobin. Similarly, when we look at platelet counts, about 1/4 will have a reasonably good or a normal platelet count. Most of them will have a platelet count in the range of 20,000 to 100,000, and a small percentage will have a low platelet count. And essentially, this points to the fact that children present usually with petechiae and ecchymosis and not major bleeding manifestations. Okay. So if you look at the differential diagnosis, which we are always taught what should be done. So the first thing is that we look at non-malignant conditions, and that we all know that it is like juvenile rheumatoid arthritis because of aches and pains, infectious mononucleosis because of lymphadenopathy, a simple idiopathic thrombocytopenic purpura, pertussis, which can be mistaken because you get lymphocytosis in pertussis, and that can sometimes make you think that, oh, maybe this is just simple pertussis. Of course, these days one sees it much less, but it can still occur. Leukemia can present with an aplastic picture. You can have pancytopenia, and you do not have to have hepatosplenomegaly. And similarly, acute infectious lymphocytosis are one of these are the common ones we keep in mind whenever we see a patient. The other malignancies which can mimic is essentially a neuroblastoma. Neuroblastoma, as it metastasizes easily, very rapidly to the bone marrow, can mimic it. Retinoblastoma, especially when you have ocular problems, it can be mistaken for a chloroma. And a rhabdomyosarcoma, because rhabdos can occur anywhere. Once they're metastatic, again, they can end up mimicking a leukemia. So in this day and age, one cannot go away from the cytogenetics and molecular genetics, which is most important in leukemia. And the two important things we look at is the ploidy status and the molecular aberrations. Okay. So essentially, you're looking at what are the good aberrations or the good chromosomal the translocations, etc., which you see, and your ploidy status. So just in simple terms, hyperdiploidy is good, hypo is bad, and the molecular aberrations of ETVX is good. We just have to remember the two bad ones, which is BCR-ABL and the MLL translocation rearrangements, which is here, which is, of course, in a less number of patients, but these are the two most important ones to remember for a pediatrician. It's otherwise, it's just too much to remember. So management, yes, as we have learned in the last 50 years, it's multi-agent chemotherapy, and with induction, consolidation, intensification, maintenance, CNS-directed therapy, your current outcomes are to the tune of 90%. A transplant is indicated only in some conditions in a leukemia in the first time round. The newer management includes targeted therapy, which is tyrosine kinase inhibitors. Immunotherapy has now come up in a big way with monoclonal antibodies, which can be anti-CD2, 22 directed, bispecific antibodies against CD19, and the CAR T cell therapy. These are the three newer forms of therapy which are kind of now coming up really rapidly. So now the unusual presentations are essentially when the leukemia occurs at an extramedullary site, right? So this can be ocular, which I mentioned. It can be if it comes in the bladder. It can come with endocrine features, unusual CNS symptoms, unusual metabolic aberrations, and funny musculoskeletal symptoms. So we'll just go over a few cases fast to make, one realize that yes, there's more to all this than really meets the eye. So I'm just going to say a 6.5-year-old little girl who came about nearly 2 years ago. She came with high fever for 14 days. She had received one blood transfusion prior to coming to our hospital. She had no history of bone pain, bleeding, jaundice, high-colored urine, decreased urine output, weight loss, oral ulcers, alopecia, or drug intake. Her past history and family history was not contributory. And we can see that she had anemia. TLC was okay, but the DLC showed a little lymphocytosis and the platelet count was low. So this child looked very well in herself, and general physical examination, except for pallor, everything else was non-contributory. So then when we did her investigations, she had pancytopenia with a low hemoglobin, low TLC, an ANC of just 120 and platelets of 20. Her electrolytes were essentially normal. And at that time, because she came with fever, workup for infections was negative. A bone marrow, which was done twice within a period of 10 days, first one showed possible myelofibrosis, which was a little, and the second one, again, they said there's a lot of fibrosis, though the cellularity was preserved. So the pathologist gave a diagnosis of a myelofibrosis. Now, pediatric myelofibrosis, all pediatricians who are listening in will know that this is an extremely rare occurrence. It's very rare in pediatrics. You can go for 10 years and just see one. And the mutations which are elucidated in adults are not seen in children. And it is seen that a lot of times it has a sort of a very benign course and spontaneous resolution can occur. Okay. So what did we do? So we just followed up this patient because we don't really have a treatment. We didn't know what to do. So we followed this child up, and on follow-up, though her TLC remained low and her platelets were also on the lower side, but we felt maybe she's improving. She was asymptomatic. So we thought we will just keep her on a close follow-up. So we followed her up, but 6 months down the line, she came with a very bad febrile neutropenia, and she was admitted with pneumonia and congestive cardiac failure. So CT showed a bad pneumonia with suggestive of a fungal infection. She received multiple antibiotics and amphotericin, and COVID had just troubling everybody. That was negative. And because she came with cardiac failure, despite correcting her anemia, the whole workup was done, which showed a very poor ejection fraction, and they felt it was dilated cardiomyopathy. All her workup for, a cardiological issue for this was negative, including her thyroid profile, immunoglobulin levels, even vitamin D, everything was normal. The family echo screen was done. That was normal. Repeat echo when the child came out of a fever was slightly better, and even a Holter monitoring was normal. So then we continue to look at her hemograms. If we see the hemograms over the approximately 1 month this child was admitted, the pancytopenia persisted. So we felt that as soon as she's in a position, because she was pretty sick, we will repeat a marrow. The biochemistry was more or less okay. Of course, she had low albumin because she was sick for so long. She had a bit of unconjugated hyperbilirubinemia, which improved. And of course, the CRP was high at that time in view of the infections she had. So when she improved, we repeated a marrow. Her marrow showed 55% blasts, with CD10, CD19 being positive. The fish was negative for the common ones which we do, and there was hyperdiploidy, and the final diagnosis was a pre-B-ALL. So after 6 months, the child was diagnosed to have a pre-B-ALL. So at the moment, this child is well in the maintenance phase. She had prolonged cytopenias for 6 months. So this was probably, the disease took so much time to evolve. Myelofibrosis can also be sort of a predecessor, or leukemia can present with myelofibrosis. But however, until you have a diagnosis, you cannot treat. So 6 months it took before finally this child got to be a leukemia. Right? Sorry. Just a minute, it's got stuck here. Sorry, this has just got stuck over here. I just figure out. Yeah. Yeah. So we come to this other little 5-year-old boy who came to us with fever for 3 months and a mass on the left side of his cheek and a cervical mass for 3 to 4 months. So this little fellow had a normal weight, height, nothing else on examination except for a cafe au lait spot which we can see in his neck, and he had a nice swelling on the left side of his face. It was like the parotid swelling and some lymph nodes. Everything else was normal. So his routine workup which was done was negative. The biochemical profile, coagulogram, and a workup for tuberculosis, because when he comes from the village, since we are endemic for tuberculosis, we very frequently work up for tuberculosis, was all negative. And then finally a biopsy of that lesion was done. This biopsy showed large atypical cells, at least double the size of a normal lymphocyte, open up chromatin, and they said that these cells are exactly like a lymphoblastic leukemia. The flow was positive for a pre-B cell leukemia. So after this, we did a marrow. The marrow was packed with 90% blasts, again with a similar flow as the biopsy. The fish was negative. It was like a good leukemia, and it was a pre-B ALL. So this child came with a simple parotid swelling, nothing else, totally normal CBC, and it turned out to have a leukemia. Okay, so we look at another spectrum. We have a little 8-year-old boy who came with pain in his thoracolumbar area for 3 months. This was much more in the morning. It was relieved with paracetamol but worsened. There were no neurological bowel or bladder symptoms, and he also had poor appetite and occasional pain in his thigh. Examination, he was comfortable except for mild tenderness in the thoracolumbar junction and mild flexion at hips and knees when walking. The systemic examination again was totally unremarkable. So now his x-rays were done, which showed osteopenia and scalloping of the lower lumbar bodies. In the T7 and T9 showed anterior wedging of the vertebral bodies. A DEXA scan was done to look at the bone mineral density, and this was less than 1/3 the standard deviation for age, which means that his bones were really osteopenic. Scan just showed uptake, and an MR scan showed an abnormal vertebral shape, but there was no evidence of an infiltration. So it was thought, is this juvenile arthritis? No one is sure, but that was just the only thing one could think of. So his investigations were very interesting. His calcium came 14.5, the normal in the lab being 8.8 to 10.8. It was really high. Growth hormone was normal, phosphate, protein, albumin, everything, magnesium, everything was in the normal range. The liver functions were also normal. It was just an isolated hypercalcemia, no other clinical features of hypercalcemia, and with these funny bone issues. His hemoglobin was okay, the TLC was high, and the neutrophils were also on the higher side. So is there some infection? And the platelet count was slightly low. Because the platelets were low and the WBC was high, a bone marrow was done. And this child also turned out to have ALL and was Philadelphia chromosome positive. So this was hypercalcemia as a presentation of malignancy. Hypercalcemia is a very rare presentation of malignancy in children, can be seen in a very, very occasionally, maybe 0.5 cases of leukemia and occasionally in Hodgkin's or rhabdomyosarcoma, but is a unusual manifestation of malignancy in pediatrics. Adults see it much more frequently. So my last case is a little boy who came with fever for 2 months, loss of appetite for 20 days and nothing else. So this child was sick. He had tachypnea and he had hypertension. He had generalized lymphadenopathy, edema, chest had wheeze, the liver and spleen were palpable, and the rest of his examination was unremarkable. So this child had very interesting investigations. He had a high TLC. His platelets were 64,000. Now in his differentials, he had eosinophilia. His absolute eosinophil count was 28,000, and his repeated eosinophil counts continued to be between 20 and 30,000, which is, from 1,000, 1,500, it's really high. The biochemistry was normal. So one investigated him for, infections and allergic problems, etc. Why should one have eosinophilia? Everything was okay. The stool examination, his X-ray showed a reticular nodal pulmonary infiltration. Is this a ABPA? The Mantoux test was negative, HIV is negative, ultrasound showed, and CT showed hepatosplenomegaly, some retroperitoneal lymph nodes. The CT was ground glass appearance of lung with mediastinal lymphadenopathy. A biopsy from the nodes showed reactive lymphoid hyperplasia. Okay. Then because he had hypertension, he underwent a whole lot of investigations for his hypertension, which is renal vasculature, parenchyma was normal, a cardiac evaluation was totally normal. The IgE levels came slightly elevated, reasonably elevated. Rheumatoid factor, anti-nuclear antibodies, the whole immunological workup, everything was negative. So it was like, all right, he has hypereosophilia. Is he having end organ damage because of his cardiac, though he has hypertension, he has hepatosplenomegaly, he had a bad wheeze. So he was treated, with symptomatically with everything. But why is he having all this? We don't know. We hunted hypereosinophilic syndrome. So it said, yes, imatinib is supposed to help. Prednisolone is supposed to help. We gave him steroids for a week. In any case, it helped his chest, not his eosinophils. And then in desperation, he was started on imatinib to bring the eosinophil count down. But we didn't have a diagnosis. Right. And this is 10 years ago when we did not have access to so much of molecular diagnostics. Then along the way, his CBC, because of the eosinophils, a bone marrow was done. They couldn't understand why this child had blasts. And it's 10%, which does not classify as a leukemia. Is it a refractory anemia with excess of blasts? But he never had anemia. It was just blasts. This was repeated after a month. It showed 11% blasts. And the eosinophils insisted on being about 20,000. So we don't know what we're dealing with. We gave him a bit of prednisolone. We gave him a bit of imatinib, kept doing a CBC, kept looking at him and keeping our fingers crossed. Finally, after about 3 months, one day, the CBC showed 52% blasts. And a bone marrow was done, which showed presence of myeloid precursors and overrods. So 3 months from the time of his first admission, finally, this child was diagnosed to have acute myeloid leukemia. He was treated, and at the moment, he has completed therapy 10 years ago, and he's absolutely well in high school. So, my take home messages are that any child who has any hematological aberration needs a very good, regular, careful follow up. Our first child had pancytopenia, took 6 months before we could diagnose it. Hypereosinophilia is a rare manifestation. Keep them on a follow up. We don't know. Was it an evolving disease? It's very difficult. We have some molecular stuff available, but we are still unable to pinpoint certain things. A lot of times, children are thought to have juvenile rheumatoid arthritis. A bone marrow has to be done before giving steroids to a child. You don't know what he may be having. Metabolic aberrations can be a presentation of malignancy, like the child we thought was arthritis, but his calcium alert was too high, and then just because his peripheral blood film had slightly low platelets, we did a marrow. And any unusual symptoms, signs which just didn't fit into our normal armamentarium of routine diagnostic workup, we need to think of a malignancy. It can get missed. So I'll end here. This is the center which our pediatric center in our hospital. And I thank you all for very patient listening.
Thank you very much, Professor Tarahan. Finishing well before the schedule time. Thank you for the excellent presentation. It was wonderful. I'm sure all the viewers have enjoyed. Now I'd like to request Dr. Hassan to show us a very interesting showcase. Dr. Hassan, over to you. Thank you, Dr. Amita. After presentation, we'll invite you for panel discussion. Dr. Hassan, please.
Assalamu alaikum, everybody. Thank you, Dr. Sahrab, for the invitation. I would like to thank the Dubai Pediatric Club for their invitation. I will be starting my presentation. I hope that you can see my screen or not yet.
Yes, please.
Okay. So basically, I am an infectious disease person, and feeling surrounded by all these high caliber hemato-oncologists make me a little bit scary because, as you know, we do collaborate with our colleagues in pediatric hematology oncology most of the time after establishing a diagnosis, and we step in when those patients started to have any kind of unusual opportunistic infections. When I was requested to do a presentation about a rare case of hematology oncology, it came to my mind this case, and I labeled it as rare and unusual. And the beauty about this case is not only that perhaps the presentation to some extent is believed to be usual, but the rarity of the disease itself is the surprising thing. So basically, this is, I'm starting with the fact that we do learn something when we are calm, but again, and some things we learn even in a storm. And perhaps the case that I'm going to present to some extent, it went through some stormy course. So basically, I'm going to go into a stepwise type of presentation, starting with the presentation of the child. Basically, this is Kareem. He is an 8-month-old male patient when he's known to a presumptive diagnosis of hypoaldosteronism, CMO1, CMO2 syndrome, not fully diagnosed. This patient was kept on fluorocortisone and sodium chloride for a bit time before his presentation to our hospital. So basically, he arrived to our Tawam hospital back in April 2021, and the main complaint was a refusal to move or to use the right hand, in particular the wrist area, with some elements of refusal to walk. And there was a history actually of fever, and there was no history at the time of presentation, so just the subjective fever, and it was only reported by parents. There was no significant family history, only his older sibling diagnosed to have iron deficiency anemia, and he was treated with iron supplements. And the rest of the family history was insignificant for any blood disorders, malignancies, or any other medical issues. At presentation, the vitals, as you can see, it's not really very striking. He was febrile with 7.7. His temperature, the saturation, the heart rate, and the respiratory rate were within acceptable ranges for his age. And generally, he was hydrated, calm in the mother's hand. He was a little bit irritable when he was approached by the medical personnel. The general exam, we noticed only a very mild pallor and no icterus, no lymphadenopathy. The liver valve was about 1 to 2 centimeters below the costal margin. And because the main complaint was, the inability to move the right wrist, the physical examination revealed only some kind of tenderness with palpation. There was no erythema, and the rest of his musculoskeletal examination were we could not observe any alterations. So the initial investigations in the ER were as follows. So as you can see, there's a bit of decrease in hemoglobin in the range of 8.9 gram per deciliter. The white BT is also in the lower some kind of range, but he was neutropenic at that point, where the ANC within 770. The rest of the hemogram was within acceptable range. I mean, the platelets also were within acceptable numbers. The peripheral blood smear that was done did not show any significantly striking thing, so it was of no use. So these are the serum biochemistry studies done at the initial presentation. As you can see, the only striking thing here is the LDH. It was a bit elevated, 397. Alkaline phosphorase was in the range of 256, albumin low, and he has an elevation in ESR and I would say moderate increase in the CRP. So the patient, they contacted us, and when we received the call, we put in our differential diagnosis of infectious disease, inability to move a hand with history of fever, type of these things. Of course, what comes to an infectious disease mind is an osteomyelitis or a bone infection. And of course, the cytopenia that has been observed in form of low white BCs and borderline hemoglobin, and the low ANC would bring in the cytopenia for evaluation. We decided at that time to think that because of absence of fever and the preliminary paraclinical testing results, namely the ESR and CRP, we decided to the possibility of musculoskeletal infection is there, but it is a bit slim, and we need to consider doing an X-ray of the rest to rule out some kind of fractures, if any, and of course to consider MRI, and no antibiotics to be started at this point in time, unless we get the at least the X-ray plus minus the MRI. So once we got the X-ray, that wasn't done in ER, and as you can see that even when they were doing the X-ray of bony tenderness also were noticed when they were doing the X-ray. And the surprise that the X-ray rest showed this destruction of the bone in the lower end of the radius with periosteal new bone formation, and the rest of the bone in the hand were remarkably. And this is the wrist X-ray showing, as you can see, reporting some kind of possibility of an aggressive lesion. Osteomyelitis is another possibility that it was mentioned in the differential diagnosis by the radiologist. This is the radius, as you can see, and it's very evident the destructive lesions in the bone. And this, of course, these findings would glitch in our mind that if we have a destructive lesion, from ID perspective, we start to think about other possibilities. Of course, not acute hemotogenous osteomyelitis, but I start to think about the possibility of what you call it, the chronic multifocal recurrent osteomyelitis as one of the possibility. And of course, whenever you have a destructive lesion on a bone, malignancy is in board. So at that point, we decided to go for skeletal survey, looking for any other, bony lesions that might confirm or exclude the possibility of chronic recurrent multifocal osteomyelitis. Bone scan, of course, MRI to have a better idea about the nature of the bony destruction. So I created this kind of, a stepwise approach just to keep you in the loop. So this is a patient who came in with an ability to move the limb. One of the differential we put in our mind is osteomyelitis. The other one, the possibility is the malignancy. And we ordered the CBC, CRP, X-ray, wrist that excluded mostly the osteomyelitis and acute hematogenous, and the possibility of fracture has been removed from the picture. And we here left up with the chronic recurrent multifocal osteomyelitis CRMO and the possibility of malignancy. So this is the lower limb X-ray, and as you can see, it's more or less showing another destructive lesion in the fibula and new bone formation in the proximal and the distal part of the tibia as well. And this also, from at that point, I was thinking, you know, involvement of these lesions or these bones also could be suggestive of multifocal osteomyelitis. And this is how it was reported. There is an evidence of abnormal pre-aortic reaction and abnormal lucency seen in the distal part of both femur and proximal and distal portion of tibia and fibula. Some bony lesions are seen involving both fibula and more in the left side. So these things have some kind of also bringing in the possibility of other destructive lesions from a neoplastic disease processes, but again, it still doesn't exclude completely the possibility of chronic multifocal osteomyelitis. So they reported as it could be a picture that's suggestive of metabolically dietary insufficiency disease rather than infectious or a child abuse lesions for further workup. At this point, we strongly started to believe that the lesion is very unlikely to be infectious in nature. And we put, as I mentioned, the CRMO, one of the possibilities, adding the possibility of Langerhans cell histiocytosis and neoplastic process. So basically going back to our algorithm, osteomyelitis and fracture has been removed, the CRMO and malignancy has been put in the picture. For this, you need a skeletal survey, bone scan, and MRI. So when we done the bone scan, it was reported as the following. So there was a non-specific raccoon eye presentation or increased uptake, and there was another lesion in the left scapula, and the bone scan was favoring the possibility of neuroblastoma, and it remained that these changes in the bone scan remained still elusive, and it represents a bone marrow activation, but we could not reach anything from the scan. And therefore, hospital admission, our patient Karim, he remained stable and remained febrile, and he underwent MRI imaging, specifically focusing on the right wrist. And to our surprise, the MRIs showed that it is the thing that the findings are suggestive of hematological multifocal osteomyelitis. However, the possibility of metastatic neuroblastoma should be considered less likely, Langerhans histiocytosis. So again, it brought back the possibility of multifocal osteomyelitis in the picture. So for us at this point, with all these, dilemma, we decided that a bone biopsy, of course, is the main thing that we need to go for in order to make, a good impression about what this bony lesions could be, keeping in mind that the lesions could be of a neoplastic process. And at this point, our pediatric hematology oncology team were involved in the case. Going back, so again, the osteomyelitis part, the X-rays and preliminary labs excluded the osteomyelitis. Chronic recurrent multifocal osteomyelitis and malignancy has been kind of explored by MRI and bone scan. The bone scan had added a new, kind of entities that need to be put in the differential. So the neuroblastoma, Langerhans histiocytosis, and the possibility of leukemia. Our pediatric hematology oncology saw the patient, and they had more or less a very similar impression that this could be metastatic neoblastoma or Langerhans cell histiocytosis, and of course the need for biopsy and from the bone marrow, from the area where it's the lesion reported. Adding to that, of course, they need to do the bone marrow aspiration simultaneously at the same time when the bone biopsy will be done to be sent for further evaluation and testing. And they requested the VMA and HPA in a urine sample just to look further into the neuroblastoma part. The patient remained okay, and he did not spike any fever. He remained off antibiotics. Of course, due to his low hemoglobin, he received frequent RBC transfusions as needed. And on day 5 of hospital admission, he underwent bone marrow biopsy and aspiration and right radius lesion bone biopsy. During his hospital stay, these are the investigations. As you can see, the LDH remained very high. His verdict was within acceptable range. Hemoglobin electrophoresis was done just to exclude the possibility of sickle cell anemia. And as you can see, the total YBCs is dropping, and hemoglobin as well as the platelets. It's started to have a more of a pancytopenia picture alongside with a low ANC since the start. His ESR improved to some extent, remained in the higher side, but again, it is not strikingly high as we see in musculoskeletal or in malignancy patients. And the CRP more or less remained in the same range. This is the rest of the investigations, and of course, if I look from my perspective, the cultures actually that was taken from the wound site, from blood, from a urine, all reported as no growth, and urine, the VMA and HbA also reported as normal. And when we get the bone biopsy, so the biopsy from the radius, it was a bit also non-conclusive. It says about that there is a crushed bone, the crushed cells, and these, bone fragments they were tested by a panel of immunohistochemistry that scatteredly were positive for the CD1 and mixed T and B cell population. And they were negative for certain other strains. Probably my colleagues from oncology would be better than me knowing what does it mean, these CD markers here. And the biopsy of the bone is consistent of an infiltrative lesion of histocytic origin that is difficult to characterize by morphology and the limited immunohistochemistry panel that is available at Tawam. So the sample was sent to another big hospital, tertiary hospital in Abu Dhabi, Sheikh Khalifa Medical City, just to have another look and do some kind of another testing or staining, just to make sure if the diagnosis could be established in the other hospital. So the current biopsy shows extensive infiltration of the bone marrow space as well, more or less of the same histocytic lesion. So until now, the bone marrow and the bone biopsy, it's describing grossly some kind of infiltrative lesion, but according to the staining that has been done at Tawam Hospital, it was a bit harsh to define the nature of the lesion. And again, they brought in the differential diagnosis, the Langerhans cytosis, as being part of the diagnosis, and other histocytic and dendritic cell neoplasm. And of course, as usually they say, you need to correlate this with a clinical picture. What the bone marrow shows, again, it's not very kind of helpful, more or less giving some kind of irregularities in some nuclei with matuating erythroid elements. And again, if you look at this bone marrow aspirate, it's not really much helpful into making a certain diagnosis with regard to this infiltrative lesion. This is the peripheral smear that was done probably at the same time of the bone marrow. And as you can see, nothing really striking in apart from having a low hemoglobin and the YBCs in range, even the platelets in this peripheral smear. And CBC and peripheral smear review are significant for moderate microcytic anemia and moderate neutropenia. So basically, the peripheral smear is still elusive and not helpful into making the diagnosis. The bone marrow biopsy, as you can see, is in the adequacy is 90% cellularity, and the hematopoiesis. The only thing that is reported kind of maybe of some value is that the bone marrow parts is showing significantly reduced matuating trilineage hematopoiesis, along with sheets of abnormal cells with irregular nuclei. And again, these things still very vague, and our hematology oncology could not make any conclusion from these reports. So this is the immunohistochemistry that was done at Tawam. And as you can see here, there are some nuclei and scattered, parts of the cells that showing positive for CD4, S100 and CD1, but again, these are scattered and not the majority, probably making the diagnosis of Langerhans cytosis difficult based on these, very minor population here and there, and the rest of the stains here down seems to be negative. So CD1 stain performed, this is part of the report from the other hospital. So again, they had more or less the same impression that, a decalcified sample, they could not do the staining, the CD1 stain. And therefore they decided to send the the slides to Mayo Clinic in the United States for second opinion and consultation, because with all these testing, the diagnosis remained elusive for both hospitals. So maybe they were thinking about some kind of Langerhans cell histiocytosis as the most probable diagnosis. So going back to our algorithm, the patient, he came in with an ability to move the hand, possibilities of osteomyelitis malignancy being raised. Initial testing excluded the possibility of osteomyelitis and fracture. CRMO malignancy has been put in the differential. CRMO and other related things has been somehow excluded to some extent based on the preliminary labs. However, Langerhans histiocytosis remain one of the differentials. And again, this is some kind of abnormal histiocyte infiltrate. We don't know what is really going on with us. So patients was discharged after 2 or 3 weeks of intensive working in a stable general condition. Nothing done to the patient. No treatment plan was done because the diagnosis remained very elusive to oncology team. And the parents, of course, in this condition, they were very, very anxious about the diagnosis. After 2 weeks from the discharge, he was readmitted, this time with fever and URI symptoms. And as you can see, his investigation showing very low YBCs, very low hemoglobin, and low ANC and high CRP. Of course, this time we started him on piperacillin tazobactam, awaiting his blood culture results. Surprisingly, during his hospital stay, during the second admission, he developed a very short-lived kind of a cranial nerve palsy, 6 and 7. And it was very surprising that it just, within 1 week, everything improved without specific intervention. And this is what the MRI showed. And new lesions perhaps appeared in the bone, multiple bony lesions within the scalp. And there is subcutaneous new findings, which actually in physical examination, you could feel some lumps in the scalp. But the brain parenchyma and the cranial nerves within normal range, and we could not really appreciate anything extra. And again, the differential diagnosis by the MRI showed that this could be Langerhans histiocytosis, leukemia, lymphoma, and neuroblastoma, plus minus other fibrous bone tumors. Bone marrow, another one was done for on day 8 of second hospital admission. And from my end, I stopped the antibiotics after all cultures reported to be negative. So on day 13 of the second admission, here what we get from Mayo Clinic reports. So the bone marrow biopsy is diagnosed as AML with monocytic differentiation due to negative Langerhans stain, and CD1 was largely negative. However, the distal part of the bone, which is the radius, is giving it a completely different thing, which is myeloid sarcoma. But they are adding that without, cytogenetics or molecular findings. No classification would be able to be done. However, they are still, talking about the possibility of Langerhans histiocytosis, despite what I've mentioned about the ML and the myeloid sarcoma. There are some few scattered population that is showing focal staining with CD1 and S100. And what they noticed that this kind of specific kind of mutation, it's called BRAF V600E. And according to the literature, this BRAF mutation has been shown to direct the hematopoietic cell differentiation into the mononuclear phagocyte lineage and away from the lymphoid and the granulocytic lineage. And this kind of mutation has been led to Langerhans histiocytosis lesions and neurodegenerative lesions in such patients. And this created some kind of another kind of confusion about what is the exact diagnosis in this particular patient. Is it the AML? Is it the sarcoma? Is it the Langerhans histiocytosis? And until this time, going back to our algorithm, everything has been excluded, as you can see. And with this, even Langerhans remains. Is it AML? Is it Langerhans histiocytosis? Is it myeloid sarcoma? We have to wait and see. So pediatric hematology oncology team was kind of confused about if to start, not to start, what to start. It's a big dilemma for them because the diagnosis remained very, very elusive. And they decided that the Langerhans histiocytosis was not confirmed, and they have a doubt about the AML part. So nothing will be done for patient awaiting the cytogenetics. The ongoing management remained the same: antibiotics as needed, fluorocortisone plus sodium chloride, and blood transfusion as needed. On day 25 hospital admission, the cytogenetics from Mayo Clinic revealed the following. So the patient had the unusual mutation. It's called MLLT3, and with a fusion of 22.2%. And this is consistent with the quality translocation 911 in the chromosomal studies. What is this? This translocation has been reported in a very, very few, if any, patients around the world as a result of causing a de novo or a therapy-related AML, and it has an intermediate prognosis. And so by this, probably most of the dilemma around this patient is being solved by having, the cytogenetics showing this very unusual and rare kind of mutation. So the OncoHemo next generation sequencing reported another thing. So it is the SH2B3. And this variant, again, may be supporting the same theory that it caused some kind of changing into the myeloid neoplasm, including a somatic mutation in at least one case around the world. And another case, perhaps it happened with another erythrocytosis and myeloid neoplasm. So our patients belong to one of the extremely rare cases, maybe the second, if not the first. And the rarity of these variants among the population all over make a kind of correlation with the patient clinical and family history is recommended by the team. So basically here, going back to our algorithm, so osteomyelitis out and the rest of the thing. And finally, we excluded the Sierra Bone neuroblastoma, Langerhans histiocytosis, and finally, probably the diagnosis has been made based on the cytogenetics as AML 911 translocation. This patient, according to our pediatric oncology team, diagnosed as acute monocytic leukemia, as SH2B3, intermediate risk based on cytogenetics, and he was tested on this kind of protocol. So the presentation with multiple bone lesions with initial impression of multifocal osteomyelitis, followed by uncertainty about Langerhans cell histiocytosis, to be finalized as a de novo T911 translocation AML with intermediate risk and prognosis. Unfortunately, our patient passed away at the age of 14 months, probably a few months after introduction of the chemotherapy due to AML relapse and failure to accommodate him into a bone marrow transplantation. He passed away at the age of 14 on 8/10/2021. May Allah bless his soul. Thank you very much for listening, and I hope it was interesting for you to listen.
Hassan, for wonderful presentation of this interesting case. Now, may I request Dr. Mustafa Al-Baroudi, the Senior Consultant Pediatric Hemato-Oncologist at NMC Royal Hospital, Abu Dhabi. Please, Dr. Mustafa is going to show us interesting cases very briefly. Dr. Mustafa, over to you, please.
Thank you very much. I'm trying to share my slides. I like to thank you for the invitation. Can everybody hear me okay?
Yes, yes.
Thank you very much for this invitation. And the presentation of Professor Amita was excellent. And my predecessor, also Dr. Ghassan, very interesting and nice cases. The only thing, there is an overlap. The two cases, number one of my cases is very similar to the case number 4 that she presented, but hers is better because my eosinophil count was 13,000. Hers case was 28. The other case that she presented, which was number 2, was similar to my case number 3. So I end up with only 2 interesting cases. The first boy presented to us in November 2020 as a 3-year-old male who was a product of a twin delivery. He was a preemie, 700 gram. His twin brother was identical, which made things a little more complicated. He had a rough postnatal life in our Corniche hospital, the major high risk gynecology and obstetrics hospital in Abu Dhabi. And then when he reached 3 years of age, he started by random follow-up in November to show eosinophilia up to 60% with the absolute eosinophil count 13. Usually an absolute eosinophil count of 0.3 is considered for the general pediatrics elevated. Leukemia, you start suspecting leukemia when the absolute eosinophil count is more than 1, not 13, actually 1, or 1.5. The experts are on debate about this. The peripheral smear showed also immature cells, 22% atypical, and his hemoglobin dropped while the eosinophil just by observation improved. Then he had basically, so the peripheral blood smear was showing some blast after follow-up, and then the patient developed hepatosplenomegaly and had to have a blood transfusion. The original bone marrow that was done in the beginning of November 2020 showed basically increased blast up to 15%. By WHO, you cannot call it leukemia unless you have 20% blasts. And this is the morphology bone marrow. This is the flow cytometry bone marrow. And as you see, it showed only 6% by immunophenotyping the blast count. So we couldn't do except follow up as he didn't meet the criteria to start chemotherapy. A repeat bone marrow on 29/11 showed definitely acute leukemia. See the comment, and this is the comment basically, and it's showing also the blast showed 22% blast, and the comment of the bone marrow showed acute myeloid leukemia, which is basically favoring a monocytic differentiation. So the chromosomes studies show that trisomy 11. Trisomy 11 correspond to a very high risk FLT3 mutation, which makes it very hard to cure and require bone marrow transplantation. So this therapy has evolved in the whole world. I like to share these slides. You see the mortality in childhood leukemia from the 50s to the 2000s declined with the development of groups. One of the groups was for the just rhabdomyosarcoma in the United States. Another group was for Wilms tumor. And the two part of the SWOG and CLGB pediatrician part of adult cancer, mostly in university centers in the United States, merged together to form the pediatric oncology group, while most children hospitals were collaborating on protocols under the name of the Children Cancer Group. Then finally, the CCG and POG and the other groups all merged due to financial difficulties and funding from the government, and established the Children Oncology Group, which is the largest group right now in the United States. The rest of the world also joined and developed PSYOP at the same time. This boy was treated with the US COG children on myeloid leukemia protocol 531, which included 2 induction that he received in the United Arab Emirates. Then he went to his nation as he's Iranian, where he received intensification 1 and intensification 2 chemotherapy. And while we are awaiting for his transplantation, he was started on a maintenance similar to the BFM, the German protocol of 83. And luckily, while he's on the maintenance, after the first induction on the AML 00531, the United States protocol, We did a bone marrow in UAE here, which showed no evidence of no significant increase in blast population, meaning no evidence of leukemia. And we sent to the United States University of Washington lab for minimal residual leukemia, and there was no abnormal myeloid cells. And this is sensitive down to anywhere between 0.1% to 0.01%, meaning it can detect myeloid leukemia 1 in 1,000 to 1 in 10,000. So we couldn't find it. So we continued the cycle 2, 3, 4 as by the previous slide. When he was in Iran, in the transplant center, they did an MRD, which showed really ours was less than 0.1. Theirs is more sensitive than the United States lab, and I congratulate our colleagues in Iran. And it showed the MRD to be still seen and detected by their lab down to basically, this would be 15 in a million, basically, cells. Very high sensitivity. This is copy of the BFM 83 and their 2 year of maintenance. We are here in the treatment. And this is the combination of chemotherapy that he's getting. He gets thioguanine orally, cytarabine 4 doses daily, once a month, and the doxorubicin every 8 weeks, and a lumbar puncture intrathecal, just to be sure that his leukemia will not spread. Recently, we did a bone marrow before cycle 9 of this maintenance, and the United States minimal residual disease is pending, but the UAE one came as morphologically in remission. So he continued to be in remission. Our second case, for general pediatrician, the message from our first case is the very high eosinophilia, more than 1 times 10 to the power of 9 per liter, yeah, which is deserve a referral to a hematologist and definitely bone marrow studies. No, it's associated. It is not a eosinophilic leukemia. It's a myeloid with monocytic features. Our other patient here, the lesson from it is that without fever, which is the most common, or bruising or bleeding symptoms, which is the most common of leukemia presentation, this boy presented with chest pain and weight loss, basically. So he was referred from our sister hospital in Ruwais, which is 3 hours from Abu Dhabi, as suspected leukemia because he had some abnormal cells. He also had a low white count. He had an anemia, hemoglobin 11.2, which is low, and the thrombocytopenia. So his bone marrow was, this other lesson from this child is how to interpret a bone marrow. And it's meant not for the general pediatrics, but we can educate you a little bit of how oncologists think. So basically, the bone marrow was successful only as a biopsy. The aspiration were not able to be obtained as it was too much fibrotic, which sometimes we see in leukemia, especially adults. And this boy is 17, close to the age of adult. So when it's too much fibrosis, then you cannot get even a drop. So you cannot do flow cytometry on the bone marrow. Luckily, he had blast and the peripheral smear, so we were able to do. So this is the morphology bone marrow with immunohistochemical stains, positive TDT, CD34, and CD20, and it's an acute lymphoid leukemia. There is a problem in this report. First problem is that during the description here, there was a mostly myeloid. There was a typographic error, which is confusing. Is it lymphoid or is it packed with myeloid? So that raised a question. So always read the fine print in your reports, the message to the pediatrician. The CD20 has different manifestation in 2 different leukemia. The Burkitt's leukemia and the regular precursor B ALL, which is the common childhood ALL, but would be high risk because of the age of the patient. So I went back to our hematopathologist reference lab and I said, please clarify those points. The myeloid and the B cell CD20, is it the type of stain that you see in Burkitt's or in precursor B? So this was the report basically. And then the physician told us that this was definitely the morphologic immunophenotypic findings is of B lymphoblastic leukemia, which is the new terminology for childhood leukemia by WHO, and it is not a Burkitt. So there's no mature B cell. One is a precursor B cell, and the Burkitt is a mature B cell. We sent this cytogenetics and it showed another high risk, and that is this patient has hyperdiploidy, but the hyperdiploidy was the extra chromosomes that are mostly seen with myeloid lineage clone. So this will make it double jeopardy. His age is high risk for this leukemia. And basically, this is how we allocate patients with high-risk leukemia and the children oncology group. We do the end of induction, minimal residual disease. And if it's more than 0.01, we do consolidation, then we repeat. So he is now getting the consolidation. The reason we allocated him as high risk, not favorable, high risk, is because of this minimal residual disease basically done in our lab in National Reference Laboratory in Abu Dhabi, which is showing persistent B lymphoblastic leukemia at less than 1%. How much less, we don't know. That's why God created the MRD, which is a test not available in the United Arab Emirates, and it defined it as a 0.37% of the nucleated cells. So this one we can measure and follow after the 2 cycles of consolidation. My case 3 is very identical to case 2 of Dr. Amita, so I can skip it. This is a patient who presents with lymphoma picture, but they end up with an almost normal white count and the neutrophil a little bit. We like them to be 1.5, but in our area in the Middle East, this would be normal, absolute neutrophil count. Hemoglobin was normal. Platelets in the referring physician was normal. When by the time they arrived to us, it was a little borderline low, but still we suspected we are dealing with lymphoma. Luckily, if you remember that the patient had an ultrasound on the 30th and the bone marrow on the holiday, national holiday of United Arab Emirates, where both myself and the interventional radiologist volunteered to break our holiday and come and do these biopsies together, bone marrow and the lymph node. So the ultrasound showed enlarged lymph nodes, and always read the fine print, there is vascularity in the periphery. So it looked invasive, basically. And so then when the radiologist is worried about being invasive, he always say rule out lymphoma in the final diagnosis. Take it seriously. This girl had a fine needle aspiration in another hospital by the ENT doctor, which was very inconclusive. And the other lesson is that never do for lymphoma fine needle aspiration. Always do either a true cut biopsy which goes through the whole lymph node to preserve the architecture from one side to the other, or do something what we call excisional biopsy if you're suspecting. So the diagnosis here of the lymph node was it was by a core biopsy, and it is lymphoproliferative, diffuse non-Hodgkin, favor B acute lymphoblastic, which was the bone marrow, and that is the childhood, consistent with B lymphoblastic. As you look, the bone marrow, to our surprise, was packed with blast, 90%, and it was also the biopsy was packed with blast, 90%, compute these. And then it was hypercellular, fat only 5%, and cells was 95%. Again, we sent the immunophenotyping, which showed the B lymphoblastic leukemia. Because of the age of the patient and the white count not being elevated, it was classified as a standard risk leukemia. She had also a favorable cytogenetics. There was 53%. All the bad players like CML, BCR-ABL, all the bad players were negative, except she had a trisomy 17 and tetrasomy 21 in 53% of the cell, trisomy 17, 25% had tetrasomy 21. If you look at these lymphoma recently published in 2021, this article, here is the date of publication. It was the study number AAL0932, which we are using to treat this patient. And to my, finally, and I agree with the slide that Dr. Amita showed, and she said the cure rate is now 90%, and indeed it is. We got stuck at 70 to 80% for almost 2-3 decades. This was the first publication where a very respected study done on 9,226 individuals showed a 92% event-free survival. Did not relapse at all after they finished their therapy according to this protocol. Indeed, her day 29 at the end of induction, bone marrow showed beautiful results. There was no immunophenotypic detected cells, which is less than 1 in 10,000. One last slide about our activities in NMC Royal Hospital in Khalifa City in Abu Dhabi. It was established in 2018. We have only 2 pediatric oncology privileged physicians, 2 pediatric oncology nurses. We have a backup from our adult oncology nurses when our nurses are off. And we consult every year about 40 new cancer cases. Basically 35 patients have been treated with chemotherapy in a private hospital in Abu Dhabi. We were the first center to do that, and we got the support of the insurance company and the government, because the government would like the private sector to play a role in the United Arab Emirates. Right now we have 16 active chemotherapy active patients with different port and central catheter. Thank you very much.
Thank you very much, Dr. Mustafa, for the excellent presentation. Now I would like to request our panelists, Professor Nitin Shah, kind enough to join us from Bombay, Dr. Hassan, Dr. Mustafa. I would like to request Dr. Kalpana and Dr. Rafi also. We would like to thank Dr. Nitin Shah really in this midnight time to join us. Dr. Nitin Shah is a professor of pediatric hemato-oncology. His profession is hemato-oncology. His passion is vaccines. He presented in our oration as well as in our vaccine. Everybody knows him. Welcome, Dr. Nitin. Our moderators are Dr. Kalpana Sengupta, Senior Specialist Pediatrician and Head of Department at NMC Specialty Hospital, Dubai Secretary of Pediatric Club, and Dr. Rafia Ovara, Senior Specialist Pediatrician at Jumeirah Clinic. She's manager of that branch and a member of Executive Committee. I would like to thank Tawfiq also for not showing the video and giving us time for discussion. Welcome, Dr. Nitin Shah. If you have any comment, Dr. Kalpana, you please start.
Good evening, everyone. Thank you to all the speakers, Dr. Trehan. Excellent cases. We've had a treat today. And Dr. Ghassan, I think your case, I'm still confused about. So there would be some questions regarding that. And Dr. Mustafa.
Once again.
Yes, Dr. Mustafa as well. So I would like to start by asking Dr. Nitin Shah, since he hasn't presented any cases, in his memory, what would be one of the most unusual presentation of leukemia that he has come across?
So there are some couple of cases that I can very briefly say without going into details. I distinctly remember there was a patient who had some renal problem, and he was being referred by a pediatric nephrologist to me saying that this child has fever and his counts are low. So I admitted him in Hinduja hospital and we did a marrow. It was normal. And 3-4 days his fever disappeared and his count became normal. He went back home. After 1 year, he came back with again fever and pancytopenia. And this time his marrow was full of blasts. Now he was not treated with steroids, or he was not given blood transfusion. He was not treated with anything in that past 1 year. So this disease is funny, and I'm sure there are some spontaneous remissions known in some malignancies. We know in neuroblastoma for sure. Leukemia also, I would say that you can have this type of picture. One more case which we actually presented from Wadia Hospital in one of the pediatric hematology meeting, where a girl had come with PUO and normal counts and a huge liver, almost 8-9 centimeters below the costal margin. I mean, all the investigation done were normal except some abnormal LFT. The marrow and refined biopsy both were normal, and we were baffled as to what these cases. And ultimately, we did a liver biopsy, and the liver was full of blasts. So it isolated liver, presented as liver leukemia, and then of course it was treated and she's doing well. So these are the two very, very funny cases. I just want to bring to one more case. This boy was around 5 years old and he had a lesion in the skull. There was a small boil-like, but it's not getting healed. And there was a corresponding cervical lymphadenopathy. So I said, no, we need to do biopsies to find out what the cause is. Of course, counts and everything else was normal. The biopsy actually showed a pre-B cell lymphoblastic lymphoma. Now we all know lymphoblastic lymphomas are, unless produced by T cells, you very, very rarely get a pre-B cell lymphoblastic lymphoma without a marrow involvement. Of course, if you have a marrow involvement, then it becomes very easy. So this child an isolated pre-B cell lymphoma of cervical lymph node, nowhere else a metastasis or any other disease. So he was like a stage 2 or whatever you call it, and he was treated on an pre-BALL chemotherapy protocol, and he's completely all right 8 years down. So these are the three very, very unusual cases. The last case that I like to mention is that there was one child who came to me. She had high fever, deep jaundice, abnormal LFTs like SGOT, SGPT were in thousands, and she had, she was being treated as infective hepatitis. Her viral markers were negative. Someone did an autoimmune workup, ANA, alchem antibody, all were negative. And after almost 15-20 days, her count little dropped. So that's where I came into picture, and I saw the smear. I mean, so many people have presented, but I tell you from bottom of my heart, the diagnosis of leukemia is in the peripheral smear. Of course, marrow is essential, but may not be essential many times. So I did a smear and it showed some blast like such. I did a marrow and the marrow was full of blasts. Now she has a bilirubin of 17, 18 with an abnormal LFT. How do you induce her? Because most of the drug that you use cannot be used in a patient with such a high LFT. So very cautiously, we kept on adding 1 or 2 drugs and building up, monitoring the LFT. And ultimately, she saw through. Now, this child was admitted 3 months back for some PUO, and that time only one count had shown around 800 ANC with a nearly normal platelet count and a little low hemoglobin, but that was blamed to the fever that she had, and no one gave a credence to that low ANC. And that CBC was not repeated thereafter. And almost 3 months passed. I'm sure she had leukemia then, and now it became worse. So these are the 3 or 4 cases that I feel were really baffling. So when in doubt, do a marrow. I think that is the dictum. We see at least 3 to 4 cases of so-called leukemia with a normal CBC, which means they have a normal ANC, they have a normal platelet, they have a normal hemoglobin. But if you see carefully, the smear will pick up blast. If not now, on the follow-up. And these children are many times treated, as Dr. Amita very rightly said, as rheumatoid arthritis or SCD, and they're given steroid without a marrow. And most of them then come back as relapsed disease. So it's a nightmare in, at least in country where I am there. I mean, the lower class steroid abuse is so random, and so also transfusions which are given haphazardly for anemia. Lastly, I will just say that I had one child who was referred by a pediatrician in a desperate situation. That child was pure septic, was in septic shock, had huge ulcerating gangrene-like lesion in the lower limbs, and like DIC-like picture, and counts were hopelessly low. And this child had received 2 transfusions 15 days before in some other hospital. Now we do a marrow, we cannot get a drop of the blood. We do a biopsy. Biopsy is almost like no cells are seen, except at one place there are sheets of abnormal cell. Now you can't do ISC, you can't do immunohistochemistry in such type of case. Now what do? The child is desperate. We give him antibiotic, we give him supportive care. And I took the slide to the pathology department in Tata, where I have very close contact with Wadia, is just across Tata, as you know. And we decided, no, this is leukemia, we must give him the best of the child. And mind you, we gave him steroid, and on 8 days counts started picking up very fast, and he became okay. And today the child is off chemotherapy more than 5 years. He's completely normal except those little scars which are seen in the lower limb. So you will, when you are in tertiary care hospital, especially in Wadia, where we see more than 200 to 250 new cases of malignancy every year, we have a huge OPD background. We will keep on seeing these cases which are, little twisting to the mind. But that's how we enjoy pediatric hemato-oncology. And I think to my friends who are listening, pediatrician, believe me, a peripheral smear is the first investigation in any hemato-oncology child, especially when you're suspecting leukemia. You don't have to really do a fancy investigation, MRI, CT scan, this scan, that. You leave it to the tertiary care. But at your level, if you do a good peripheral smear by a good pathologist, and remember the old adage, they say that your eyes will only see what your mind knows. So the pathologist has not seen blast. He's not going to report one. He will say abnormal lymphocyte, large cells, but he won't call a blast a blast. And I think that's where, like Dr. Mustafa, Dr. Hashan, Amita, whosoever is treating hemato-oncology patient, they see their own smear, and it is such a pleasure to diagnose a rare case of leukemia just based on a peripheral smear.
Yeah. Thank you, Dr. Nitin. Very interesting cases as usual. I'll wait for Dr. Rafia. She said she had some questions to ask. Dr. Rafia.
Good evening, all. Good evening, all. Thank you very much for the very nice presentations. Good evening, Dr. Sohrab, and as usual, congratulations for every successful in Dubai Pediatric Lab. Now, my question to Dr. Amita. There is one question from Doctor asking, after facial palsy, do histologic heat ray showed an punched out lesion or his urine and sodium checked for diabetes insipidus, which may one of the manifestations. Do you understand it, doctor? It's not so clear.
I'm sorry, I'm a little confused. He says, after facial palsy, do histiocytic children head show any punched out lesion?
Oh. Oh, I think probably Amita, he wants to say that in LCH, can you get insipidus? Or is the other way, insipidus can be only the presenting symptom of
Yes,
LCH?
it can.
Yeah.
LCH, well, I think, thanks. LCH can present only with diabetes insipidus, which is why in diabetes insipidus, when you get a scan done, you get certain signs in your sella, which give you the diagnosis of, point towards the diagnosis of histiocytosis. And you can, in an X-ray of a child with suspected histiocytosis, you can get punched out lesions. And another differential diagnosis of punched out lesions in a child is neuroblastoma. So these two things you should remember in malignancies. And if you're living like we do in an endemic area, if you get punched out lesions in your skull, you also have to remember tuberculosis. I hope, Wajid, that answers your question.
Yeah.
I will just add, Dr. Rafi, if you permit me, that when you have a child with Bell's palsy, don't always think it's just Bell's palsy and nothing else. Look for the subtle neurological symptoms. Do at least a good CBC and a peripheral smear, because isolated Bell's palsy can be presenting symptom of a patient with leukemia.
Yeah.
Okay.
Especially when you're going to use steroids, then you can mask the disease for some weeks.
Okay. Dr. Kalpana, I want to ask another question, because all of the doctors speaking about the presentation of the leukemia, but we didn't speak about the treatment. I want to ask Dr. Mustafa, what about the stem cell transplantation in the patients that having leukemia?
When the toxicity of the bone marrow transplantation is higher than the toxicity of chemotherapy protocols, the current that we are using. especially with the invention of the immune therapy now. We have anti-CD19, anti-CD22, anti-CD33. We are using and upfront with the chemotherapy. So it's immunochemotherapy. The toxicity is way less than a bone marrow transplant, even if there is a full matched sibling donor. A lot of, so basically, we leave the transplant to the relapse cases. Right now, for the standard, there is a competition between immune therapy that you hear about. We call it CAR T cell, chimeric antigen T lymphocytes treatment, which is training the immune cells, the T cells of the patient on how to fight his own leukemia. And it was done successfully. And there has been 10 and plus years of remission in those patients who were very hard treated, very, very hard to cure. But until now, it is still investigational. More than an allogeneic full match sibling donor is the primary treatment and the preferred treatment for relapsed leukemia. So upfront in first remission, we don't do unless it's the myeloid leukemia, and the myeloid, it has been defined by WHO and the modern protocols, which molecular changes are considered high risk, or if they don't respond to the first 60 days of induction, then you allocate them to bone marrow transplantation in the first remission. But generally speaking, bone marrow transplant is for second remission. I like my colleagues from India to comment about this also.
Yes, please,
Professor
Doctor.
Anita or Professor
So I think what we do is we follow an algorithm where, suppose in acute lymphoblastic leukemia, if they have those high-risk cytogenetics upfront, then probably we will consider bone marrow after the first remission if there is a suitable donor. And we also go by MRD. I mean, the whole idea of doing MRD is to guide your therapy. One is to escalate your chemotherapy after your first or second cycle, or even to transplant them if they have a really bad MRD positive. So anything between above 1% definitely will go on high risk block. And probably again, if the sibling donor is there, we may consider that as an option later on. And if anything between 0.1 to 1, we will wait for the second induction. At the end of the second induction, if the MRD is below 0.1%, then we will leave them alone and continue with the same chemotherapy. Otherwise, we'll escalate to the high risk. So based, and of course, as you said very rightly, if the relapse is there, again, we are in a public hospital. Of course, Hinduja is a private hospital where I work, but my major work is in Wadi Hospital, where it's not easy to do transplant because of affordability, because of the toxicity, infection rates are high, donors are not easily available, etc. So even in relapse setting, if there is a late relapse and if it is non-T cell, and if the patient is MRD negative after first few cycles, then we would probably still continue to give him chemotherapy, especially if there is no sibling donor.
Okay, thank you, Doctor. Dr. Kalpana?
Yeah, coming back to the, basics, like a pediatrician has several opportunities to pick up leukemia, or let me say not to miss leukemia. So my question would be to Dr. Ghassan from infectious disease point of view. I'm sure you come across a lot of cases of pyrexia of unknown origin wherein you would be able to tell us which are the pointers clinically or on investigations that would make us aware, or at least we should not miss a diagnosis such as leukemia. So.
Thank you, Dr. Kalpana. I think as everybody knows, the most important thing that we learned in medical school is everything starts with physical examination and history. And if you take a very good, history and you do a proper physical examination, probably you would narrow your differential diagnosis into 1, 2, 3, 4, where you would then tackle these, differential diagnosis by investigation. So if you would miss anything in your physical examination, probably you will not reach a diagnosis. But fever, as my colleagues mentioned, not all the time the presenting, feature of leukemia or malignancy in general, but a classical teaching says, yes, fever is one of those. And of course, what's really picked up by the physical examination will tell us, are we going into the direction of malignancy or not? As everybody knows, a lymph node here and there, a big one that is unusual size and unusual size, probably would trigger the possibility of neoplastic process. As we mentioned, bone pain that cannot be explained by infectious etiology, things that also hepatosplenomegaly, etc. Preliminary investigations, what I do see, really striking thing that one, because I do work most of the time with musculoskeletal infections, these changes in the CBC-CRP is not really most of the time helpful in terms of getting into the differential between infectious process of the bones versus the malignancy. But the ESR is really kind of very strikingly important in these cases. What I've seen that, ESR of 100 and plus usually is not really the thing that we usually see in the cases of just simple infections related to common infections. Musculoskeletal infections usually doesn't give us strikingly high ESR, and these numbers probably should alert the pediatrician about the possibility of whatever unusual thing, not only an infection, is not to extrapolate and look further into the zebras. So basically, again, I just like to repeat, medicine, nothing but physical examination and history, and the labs only things can help us. So the physical examination probably will give us a lot of clues about what are the possibilities here. And if you look at even the cases that have been presented, the good physical examination probably picked up the main find that led into the final diagnosis of either being an infectious or non-infectious etiology.
Right. Since we are talking about your case, doctor, I would like to ask that retrospectively, do you think that there could be a change in the order of investigations in any way? For example, I think bone marrow was done after MRIs of various bones. So would we think about doing bone marrow earlier? And secondly, as I told you that I failed to understand till the end, we didn't have clear diagnosis till very end in that case, very complicated case. So is there any possibility that AML, sarcoma, LCH, they have some related etiopathogenesis? Why was it like that? So I think even the oncologists can pitch in on that question. But definitely, could the order of investigations have been, different?
Yeah, Dr. Kaplan, let me tell you something. I mean, when I just placed this, investigation in order, most of the investigation has been done within less than a week. So the MRI, the bone scan, the X-rays, probably within 1 or 2 days maximum, everything has been done. But I put it in this order just to make, the issue that this is how things went up. But mostly, even the bone marrow, as I mentioned, I do believe it was done maybe on day 4 or 5 of hospital admission. And the difficulty here is that perhaps my colleagues from oncology can, I think they would expect to see something in the bone marrow or in the bone biopsy that be confirming the diagnosis, but this did not happen. And this is bringing in the difficulties into giving the proper diagnosis. And it took us a long time until we sent the, the samples to Mayo Clinic and we get back the reports. And probably my colleagues, they can comment more than me on this aspect because I can tell about the infectious disease part. I worked with this child a lot with because he developed many infections during his chemo. But again, the oncology part, I tried to, what I could understand from the file to bring it to you.
No, it was a very interesting case. I would definitely like opinions from our esteemed oncologists here. Yeah. Yes, Dr. Nitin.
So, see, to answer to your first question of when does a pediatrician suspect malignancy? Of course, all that Dr. Gassan said, Dr. Mita showed are the telltale signs which are there. Even a blinder can be picked up. But subtle signs, like subtle weight loss or not gaining weight in the last 3 to 6 months. Awakening at night is very, very, very important sign. If child gets up at night with pain, it can't be growing pain. Number 3, when you are pushed to the wall with fever and you think of infections and you're investigating, as Dr. Gassan's case, if there are counts which are falling and not improving over the time, think that you need to do a marrow that time. Then we tend to do markers of cell turnover, uric acid and LDH. If you have an infection, depressing marrow, you have something, then you expect uric acid to be low, you expect LDH not to be high. But when you have very high LDH in a patient with PO, suspect that there could be some malignancy if you have ruled out megaloblastic anemia. And last but not the least, a child who refuses to go and play down, subtle sign. He's lost interest in the play, he doesn't want to mix with people, he wants to be lifted all the time. He's having some bone pain, even though it may not be classical. Now, coming to the order of investigation, I think the order of investigation depends on patient presence first to whom.
Presentation.
If it presents to hematologist, we have a very low threshold doing a marrow. If it
Or
goes to a
bone marrow.
rheumatologist, they'll keep on doing LE, ANA,
Antibodies.
ROLA, antibodies. They go to infectious specialists, cultures, bone scans. I think that's perfect. I mean, but so far as there's an interplay between the two systems in a patient, like Dr. Ghassan's patient, who is not improving on a line that you have thought of,
Yeah.
I think it's worth doing a cross consultation, and then maybe a marrow will come. And I'm sure they did the marrow quite fast. And in fact, the marrow did not pick up the disease initially.
No, it didn't. So also wanted to know what is the importance of the CD1A stain that doctor spoke about. Dr. Amita?
You know, I think it sometimes what happens is even the pathologists, some things just end up coming positive, which we can't explain. So it's like one is always wiser in retrospect.
Absolutely,
You know,
that is true. But that's
so
how we
it's very
learn for
difficult
the
because
next.
even we've had occasions of a similar nature when, you know, some stain comes up positive and then you keep beating around the bush for the next couple of months and you're not able to explain it. And then sometimes it's blamed that, okay, maybe the antibody was old or there was some issue with. So, I mean, I'm not able to give a scientific explanation for this.
I think if you have S100 and a CD1 very strongly positive in a clinical background or suspecting LCH, I think that would probably make the diagnosis. And you can have it only on the bone marrow or on the skin biopsy. And very rarely you can have an isolated pulmonary LCH, which is like a nightmare to diagnose because there's nothing in the periphery or in the marrow which you can pick up. And doing an invasive lung biopsy in a child who is breathless and sick is difficult, but I think it's worth it. Same way if you have an isolated liver LCH, again a liver biopsy, because they come as cholestatic jaundice and nothing else. So in all these patients, if you carefully strip the patient and look at the lesion, you will find probably some skin lesion somewhere, and maybe that's easy to biopsy and diagnose.
Okay.
May I interrupt? One teacher we had, he said, if a child comes to you with back pain, which is there for sometimes, think of malignancy unless otherwise. I mean, what is your opinion? I say back pain in a child, which is constantly there, is an unusual sign. What is your opinion?
I would say back pain or any bone pain, even if the refusal to walk, refusal to put the foot down, getting up at night with a lot of leg pains is equally important as much as backache. Backache will be a little older child, yes. And you can have not only malignancy like leukemia, but also can have a retroperitoneal mass like a neuroblastoma or something coming with severe back spasm and back pain, especially when there is entering the nerve root.
Right. Dr. Mustafa, I would like to ask you, what are some of the important clues on investigations? I know we have gone through it, but just to summarize, important clues on our basic investigations that a GP or general pediatrician orders.
Only 10 to 20% are what we call aleukemic leukemia, meaning the peripheral smear does not have blast. So I am very lucky with my hematopathologist. And also for pediatricians who are practicing in the periphery, their pathologist, although he's not hematopathologist, general pathologist, they are an excellent resource that can help the pediatrician circumvent an unnecessary consultation with the pediatric oncologist. Most parents, I would say 50% of the parents who come in a private practice like ours for consultation, they didn't sleep the night before. 50% sleep, they don't know what they are getting into. And 50%, the minute they know their child needs attention of a hematologist or oncologist, especially US boarded doctors, they don't differentiate between hematology and oncology. It's only one board. So establishing a relation with the pediatrician and his pathologist, although he's not hematopathologist, but they are very good resource. And most of the time, I get on my WhatsApp pictures from the microscope of my colleagues down in the lab, patients who I don't know, but they are seeing some unusual findings, and they alert me that this might be coming for you as a consultation. So as the professor said, is that the blood smear is very important and underutilized, and the relation with the pathologist is underutilized, really. Some centers are small, they don't have a really expert or experienced pathologist. It's a tough situation. But most of the centers, they have a good experienced pathologist, and then you can use them as a resource. As Dr. Hassan said, history, physical. For instance, I had a presentation in rare disease of children in Dubai the other day. And basically, you have to look at that MCV. Large MCV, I was told by my teachers that the marrow is struggling. Especially if you do B12 and folate and they are normal, the baby is not being breastfed and the mother B12 deficient. If you are lacking this in a child who is 3, 4, 5 years coming with pancytopenia and the high MCV, this needs investigation, needs bone marrow sooner than later. This requires referral. So you have the blood smear, you have the MCV to look at. Especially in our area of the world, 40% have small MCV. So when you see a large MCV, immediately refer to an oncologist. Bone marrow is needed sooner than later.
Okay.
And
Dr.
if I
Amita,
could
you
add-
mentioned
Yeah. No, I just wanted to add.
53%.
Yeah.
Sorry, I just saw on your slide, if I'm not mistaken, 53% less than 10,000 total count. Is that right? Because
So it's not necessary that you're going to have high counts in a leukemia. There's only a small percentage which will have counts more than 50,000. Most patients will have a count in the more or less normal range, which is less than 10,000, 7,000, 8,000, 9,000. Some will have between 10,000 and 50,000, and that 15% odd above 50. So, and I just wanted to add to what Dr. Mustafa has said, that for a person in the periphery or a pediatrician, an important little sign is that when you're looking at your TLC and your differential, if you have a very high lymphocytosis, your neutrophil lymphocyte ratio is reversed, or your lymphocytes are very high, that is one thing which can be it could be like, because your leukemia is a lymphoblastic. So that could be a small sign in which will signal you to the fact that this child be having a leukemia rather than something, an infection. Because it's only viral infections which will have lymphocytosis. Otherwise, you really get neutrophilic leukocytosis, not lymphocytosis.
Yes,
So just to add, Dr. Kalpana, that I think very clear message to the pediatrician, it will help them in the practices. When you see a blood count, CBC, complete blood count, always calculate absolute neutrophil count, ANC, and also absolute lymphocyte count, ALC. Now, if you have a low ANC in a patient with abnormal counts or even with a normal count, that tells you that the marrow is not throwing out neutrophil. Either it is infected or it's infiltrated, or it is depressed, or is having nutritional deficiencies like megaloblastic. So keep a watch. This is not simple case, and the counts have to improve once the infection is under control. Otherwise, this child needs a smear and a marrow. Same way in a small baby. Suppose you have a 2 or 3 month old child and his absolute lymphocyte count is 1,500, 2,000, 2,500. You'll be worried that his T cells are knocked off, because the baby is a lymphoid organ almost till first year of life. You'll see a normal 2-3 months old child will have counts of 10,000, 80% lymphocytes. So that's the way it should be. But if it's 20% lymphocyte, then that tells you that the T cells are knocked down, and then probably this child might be a case of immunodeficiency. So we're not talking malignancy, but it helps you. So calculating ANC and ALC, what happens is pediatrician says WBC is 6,000, normal, but he doesn't see that the neutrophils is 20%, which means the ANC is 1,200. Now it's below 1,500. You need to keep a watch by repeating count after 2-3 days, 4 days, 1 week, and see that become in normal range. If it's falling further, he needs to be referred for bone marrow. So I think calculating ANC is very important.
Dr. Nisha, we see majority of children with viral infections, usually there is lymphocytosis. Close to 75% after repeating it calms down. At which point, I mean, you said this thing, when suppose this facility is not there, at which point, I mean, you go for that, because we see after viral infection, many children, they have this.
Yeah, but Dr. Sorab, they will have near normal ANC or even actually normal ANC. So the counts will be 8,000 with 80% lympho, but 20% are neutrophil. So that makes the count 1,600 ANC. You are not worried in that child. As compared to a child with 6,000 count and 80% lympho, now the ANC is only 20%, that is 1,200, and you are worried. So I think it's not only the total count and relative lymphocyte, but it's also the how much is the actual neutrophil count. And that is important to guide you further to see which patient you need to watch out and refer to your colleagues for further consultation.
Doctor, what about the ESR? What about the ESR?
You asking me?
Yes, yes. Yes.
I mean, ESR is a very non-specific marker in children, and in adults, of course, because they have a lot of chronic inflammatory condition, it's a very useful for prognostication. But as a diagnosis, ESR alone doesn't matter. But if I have a child, say a 6-year-old child with PUO and a 3-digit ESR, it will tell you probably it's either malignancy or rheumatological condition. Whereas if it is 2-digit ESR or 20 ESR, that's almost like normal, then I wouldn't worry. Otherwise, suppose you have a patient of SLE, he's supposed to have high ESR, and now the suddenly ESR has fallen to 20. I'm worried that there is a macrophage activation which is setting in, especially if the child is also becoming sick with fever reappearing and the counts falling. Then I would be extremely worried about macrophage activation syndrome, and maybe watch for that, because if you don't treat in time, you may lose that patient. So ESR is more prognostication rather than a diagnostic value.
Then the most
in leukemia, ESR really, I don't look at it.
Yeah.
Basically, low, high, I use other parameters to suspect leukemia.
Then, Dr. Mustafa, what are the very important inflammation markers that we look that you look for the leukemia?
We know leukemia patients have decreased neutrophil reserves. If not neutrophil count already on the peripheral smear, their reserves are not so great. So and if there is fever, you need to respect your pediatrician CRP. It's a very popular test. And I came across a small article, it's not evidence-based, that the magic number is 80 to start antibiotics. But if you are more conservative, CRP of 40, you can start antibiotic. But definitely if it's 80 and a patient is febrile, cover the antibiotic until your cultures come back. In oncology, we always do cultures because we have catheters. So we worry about catheter-related infections.
Okay, thank you. Dr. Kalban.
Dr. Trehan and Dr. Mustafa both mentioned the importance of the percentage of blasts. So I want to know, if you see 15% blasts and it's not leukemia, what else is it like? What would be the differential?
The one I presented, I've seen cases where after a viral suppression, you get a hypertrophy, left shift, which can manifest as 15%. So basically, you keep them under observation and you prepare the family that they're going to be another marrow for this child. 2 weeks is reasonable, but sometimes you might require 4 weeks to do the repeat bone marrow. And leukemia will not hide itself during the observation period. Something will show up, drop in the hemoglobin, other parameters.
Yeah, by definition, leukemia is more than 20% blast. So if you're getting 10, 11, 1, as Dr. Mustafa said, it could be evolving. The second is it could be a myelodysplastic syndrome. And in myelodysplastic syndrome, you get a condition where there's excessive blast. It will remain in that range. It will not, I mean, it can become a leukemia, usually a myeloid. Yeah. It could be just RAEB. So these are two things. And the same thing, I mean, I think all of us would do exactly what he has said, just keep the child on a strict follow-up.
So I would just add, a lot of time you can see a syndromatic child. it's more common in syndromatic child. But the second marrow should include the myelodysplastic molecular studies. There is a panel commercially available, and you just run it and see if you can run into some translocation that's predisposed to leukemia.
So for
just to
example,
add,
you have
Dr.
a
Kalpana,
yes,
that you can also get blast in the pelvis smear in a patient with JMML, what you call juvenile myelomonocytic leukemia. It's actually not leukemia, it's a myeloproliferative disorder of children. So that can happen. They can come with hepatosplenomegaly, pancytopenia, and they can have blast. The other thing is, many times people have, I mean, some blast can be seen in patient with a lot of organ involvement, like in patient with some storage disorder. And in a very small baby, some cells look like blasts, but they are not actually blasts. They are what we call hematogones. So you cannot differentiate unless you do a flow. So in a small baby, you should be worried that you can have this type of picture. And lastly, never forget osteopetrosis. If you have a lot of consanguinity in your areas, the osteopetrosis can be common. They can come exactly like pancytopenia, leukoerythroblastic picture, hepatosplenomegaly. The only differentiating feature will be, of course, consanguinity, and they will have nystagmus because they have also involvement of the other nerve canals. So blast can be seen in this condition. And lastly, in a patient with leukemia who has been treated with nucine, GCSF, that is colony stimulating factor, if you give excess of that, then you can have blast coming out. But this is a normal blast. So there are always blasts even in a normal marrow. That's how we are alive. But they have to be differentiated from abnormal blast by doing an immunoflow. As if you have any doubt and if you see blast, always run a flow and it can differentiate between a hematogone and a blast.
Sure, thank you. So I think it's pretty late. We will just be asking one-liners now. And question is, now we have spoken about the hematological investigations and their importance. There are a couple of questions Dr. Sharif has been asking about the importance of chest X-ray and CT scan in diagnosis of leukemia. So Dr. Nitin, maybe you can take that.
Chest X-ray is always part of any diagnostic PUO as well as leukemia, because you want to see for chest mass or infection like tuberculosis or fungal infection. But CTs usually be avoided at the time of diagnosis. It doesn't add to the value unless you have a lymphoma leukemia syndrome where you have mass like a T-cell lymphoma. Then chest CT and a CT guided biopsy will help. But later on, when you start therapy and patient has PUO, cytopenia not responding, you want to see for aspergillosis. Then, of course, CT scan is very important, but not upfront as a diagnostic procedure.
Right. Yes, Dr. Afia, you wanted something?
Yes. I want to ask Dr. Mustafa, is there any protocol or any program we can support the parents who are suffering from leukemia? We know that in America, they make like a very important program for the parents to guide them, to support them. What we have in UAE or in your hospital?
In UAE, of course, the candle lighters, when I was in the United States for 20 years, we had the candle lighters meetings every month. And those are parents of older children who survived or did not survive leukemia, counseling the new patient and inviting a nurse or a doctor and some snacks to give a talk about leukemia. I worked in Tawam Hospital for 13 years in Al Ain, and I tried to convince, of course, this kind of gathering need to be initiated by national, not by expatriate. Then they need to do the necessary legal position for themselves. But they are private. One child I treated in Al Ain, the mother told me after he finished therapy, none in her family knew he had leukemia. He went through all the treatments, including lymphadenopathy after he finished the therapy, and a biopsy and a port and removal of the port, 2-3 years, and nobody. So they are conservative. They don't want their, when we do our yearly, in Tawam, we do a yearly leukemia day or pediatric oncology day. Only 1 or 2 families national comes. Most of them are non-national. So it's very hard to initiate. And when I came to the NMC hospital, I found my adult colleagues already started with the adults. And Dr. Aranda who is privileged as a pediatric oncologist in our center also, herself had breast cancer. She's a survivor. And she remembered very clearly that program in adults where a person who have been finished therapy, and she was counseling the others also. So the new patients counseled the old patient. Right now, Dr. Aranda is motivated and myself to try to start something in private hospital, similar to what our adults are doing in our hospital.
Thank you.
Right. Once the child is diagnosed with leukemia.
Can I say one more thing about this? Yes. The thing that went online now is the social media. So I have some patients who come with so educated questions about their child leukemia. I say, where did you get that? She said, we have the WhatsApp group. So there is all kind of groups that patients can join in this modern day and age. And maybe Instagram.
They will read, they will join, yeah.
Yes, Dr. Iman Shamsi, who was with us in Tawam, now moved to Sharjah Qasimi Hospital. She has a presence in Twitter. So there is now more chances for people to interact and families support.
Now in India, it is almost midnight. Tomorrow they have to go to work. Doctor.
Sure, we can wrap it up, doctor. No problem. But we have a lot of questions left unanswered, probably, because of lack of time. Maybe we can do another session later and cover those up.
Thank you very much. I would like to thank Professor Trehan, both Nitin Shah from India, Dr. Ghassan, Dr. Mustafa. I would like to congratulate Dr. Nitin for marriage of his daughter. He has really, he had a family engagement. He left and came to our meeting. We are grateful. Thank you very much, Dr. Kalpana, Dr. Rafia.
Thank you, Dr.
Mr. Tofil, thank you very much. He didn't show even his video, how kind. He is really. I would like to thank all viewers. Midnight, they are following us, more than 500. Our winner we had one winner, Dr. Liji Matthew. I don't know from where. Thank you very much. We will send him a token of appreciation and a certificate for answering our question. Rudolf Wilko, the father of pathology and the person who named leukemia as leukemia. And I would like to thank all of you, especially Dr. Trehan and Dr. Nitin from India. Thank you very much. Any final word, Dr. Kalpana, please?
No, it's all good. I think, like I said, there are some questions which we would like them to answer probably later, or we'll post them to individual panelists and they can send the answers because people have been asking. But otherwise, thanks to all of you for highlighting this very important subject. Thank you.
Thank you. Thank you very much.
Thank you very much.
Thank you. Thank you so much.
Thank you so
Thank you.
much.
Good night. Thank you.
Good night.
Good night.
Live بعدين
Pradeep.